Okay, this is Chapter 12, Drugs that Affect Urine Output. You can read the objectives. Diuretics refer to pills with many different actions. It's a blanket statement for drugs that increase urine output. Some patients may refer to them as water pills. And the term "where sodium goes, water follows" is very true in the sense that all diuretics manipulate sodium. The goal to manipulate sodium is to get it to exit the body or get it to excrete from the kidneys in order to remove the excess water that is in the body. A lot of the excess water typically isn't in the cardiovascular system. It's in the interstitial compartment of your body, be it your lower extremities. For liver failure, it could be in your belly, etc. And that's what we do to get rid of excess fluid in your body. Diuretics do treat high blood pressure, heart failure, kidney disease, and liver diseases. Those are all the big three diseases that will cause fluid overload issues. And diuretic therapy increases the risk for dehydration because you are manipulating the water amount in the cardiovascular system. So there's always a risk for dehydration with that. So it's really important that when you are given diuretic drugs, irregard to what type of diuretic drug it is, you always want to assess baseline electrolytes, because when you are given, when you are manipulating electrolytes, you want to make sure that they aren't already depleted, because you'll create another issue. You also want to assess for blockage in the urinary tract due to BPH, which is benign prostatic hyperplasia. We'll learn about that a little later. And you want to make sure, for safety reasons, that the patient have access to a urinal or a caulight, because then if we're increasing the patient's urge to use the bathroom, we are increasing the patient's fall risk. And if we don't have those safety measures in place, the patient could subsequently hurt themselves attempting to go to the bathroom on their own. And after the fact, you want to check the vitals every 8 hours. You want to monitor for orthostatic hypotension. And basically, orthostatic hypertension occurs when someone tries to go from a sitting position to a standing position too fast. If they already have low cardiovascular volume to begin with, because the diuretics are manipulating their fluid volume, they are more likely to have issues with orthostatic hypotension. You want to monitor for intake and output, because you want to make sure, especially with patients on diuretic therapy, that we want to make sure their output is greater than their input, because we're trying to pull excess sodium from them. Typically, patients who don't have fluid issues or fluid balance issues, what goes in should come out, and that number should be the same, and we call that balanced. But for patients who are on diuretic therapy, we want to see that they have greater output than input. Again, the electrolytes, we're manipulating sodium, we're manipulating potassium as well. So you want to watch for that. And you want to weigh the patient daily, because the most accurate form of assessing fluid status would be the weights. Daily weights. So most of your heart failure, kidney failure, liver failure patients will be on daily weights. And pretty much the same things that you watch out for as a nurse is what you want to teach the patient to watch out for. You just want to explain it to them in layman's terms. So tell them to take as prescribed. Early in the morning is best, probably because getting up in the middle of the night multiple times will interrupt their sleep. Tell them to never double dose. Report hypotension or signs and symptoms of it. So you want to encourage them maybe to get a portable sphygmomanometer that they can get from Rite Aid or something. They also can drink a normal amount of fluid. There's no reason for, well, it depends, to be honest with you. Patients in heart failure who are also on diuretic therapy and are on other heart medications that we'll learn about later. Sometimes they're on fluid restrictions, but in general, if they're on maybe one diuretic pill, like a thiazide drug, they could very well just drink what they normally do. Okay, there are three major types of diuretics, and then there's subtypes, which we'll talk about. The three major types: one, natriuretic, and natriuretic refers to diuretics that causes the discharge of sodium through the urine. So every diuretic that falls under the natriuretic type of diuretic will increase sodium excretion. Also include loop diuretics and potassium sparing diuretics that we will talk about in a bit. Osmotic diuretics are basically diuretics that prevent reabsorption of the water and the sodium. Typically, we don't talk about osmotic diuretics that much, in the sense that the two major drugs that fall under osmotics are, one, mannitol, which is an OR drug. It's given in the OR. Nurses on the floor do not give mannitol, but we do give isosorbide, and that falls under osmotic diuretic. Basically, osmotic diuretics, they increase the osmolarity of blood. So when you're increasing the osmolarity of blood, you're decreasing the water content of the blood. And therefore, we want the patient to lose water, and this is exactly the effect it does. It also increases the blood flow to the kidneys, and it is usually reserved, again, for critical care of the OR. Isosorbide you'll see in practice. Actually, you'll see that in clinical this term. Carbonic anhydrase inhibitors. Basically, we use this for glaucoma because it is an enzyme that converts CO2 to water, CO2 and water to carbonic acid. And stopping this enzyme typically leads to diuresis, generally, of urine, and it decreases the intraocular pressure in the eye, which is why it is a really good drug to use for glaucoma. So here is a subclass thiazide diuretic. Thiazide drugs are the first line choice of drugs that a doctor will prescribe if you are a newly diagnosed patient with hypertension. Diuretics, just so that you are very clear, there's a few things that you need to remember. Diuretics do not cure high blood pressure. It only controls the problem. So if the patient stops the medication, the problem's going to return. And the problem also is that you have a really high incidence of people being compliant or not being compliant because of the decreased libido that it causes for both men and women. Okay. Examples of thiazide drugs are chlorothiazide, hydrochlorothiazide, and metazoline. The ZIDEs should indicate that this is a common name ending, and metalazone, ONE or ZONE, I won't say 100% because I think there are other drugs that do this. Side effects causes fluid and electrolyte imbalances, and you can avoid some of these side effects if you have lower dose. I also want to make it clear that the mechanism of action of a thiazide drug is that it inhibits sodium reabsorption, also chloride, from the convoluted distal tubules. And I do have a picture. If you look here, this is basically a nephron exploded, or in detail. You got your Bowman's capsules here, and as it goes on, I like to call it the radiator. It has the radiator loops, and then it has the loop of Henle. You have the descending and ascending loop of Henle, and then you have your distal convoluted tubule. Alright, and this is where thiazide drugs work. And loop diuretics work down here. Okay? So before administering a diuretic, you want to check potassium levels because, you know, the same place, let me see if I can show you this. I'm not sure if this is the one. I don't see potassium here. However, when you are excreting potassium, sodium, you are excreting potassium as well. So you want to watch for the patient's sodium levels because they will drop on this drug. And you also want to take an apical pulse for 1 full minute because you want to not only check to see if they have a pulse, but doing an apical pulse for a full minute ensures that you are assessing the rhythm and the regularity of the patient's pulse. So it's really important to do that. And also check after electrolyte levels. And again, the same things that you are watching out for as a nurse. You want to teach your patients to look out for themselves. You just want to explain it to them in layman's terms. Teach them about signs and symptoms of hypokalemia. So you yourself need to know that first, and then you need to explain that to your patients. Also tell them to take all prescribed potassium supplements because being low on potassium is a dangerous thing. For older adults, dizziness, lightheadedness is more common and hypokalemia is more common. Remember, with older adults, everything is delayed and slowed and diminished, and they are definitely in a position to be affected by everything that happens to them. Loop diuretics. You know what? Let's take it back. Potassium level, you need to know the normal, which is 3.5 to 5.0. I know your book says different things throughout various books, but 3.5 to 5.0 is the levels that I want you to go by. So, loop diuretics, they act on the ascending loop of Henle, which I've showed you in the kidney. Loop diuretics are the most effective in patients with impaired kidney function. So here's how it works. When you are a newly diagnosed patient with hypertension, typically they will start you on a thiazide drug. You progress to loop diuretics if and when you begin to have kidney damage, because now the thiazide diuretics won't help you because you need something stronger, and loop diuretics are definitely the most powerful diuretics that you can take. As you can see, the endings of the words MI or IDE is a commonality that you may want to consider memorizing for that. Loop diuretics inhibit sodium reabsorption, and the difference between this and the others, it also causes vasodilation. And they use this with not only hypertension, but heart failure and nephrotic syndrome, if a patient has any cerebral or pulmonary edema. Side effects are greater because it's a stronger drug, so greater water, sodium, and potassium loss, calcium loss in urine. Adverse effects, fainting, falling when changing positions, because again, it increases the problem with orthostatic hypotension because it decreases the readily available cardiovascular fluid volume. And really important to note, it causes ototoxicity. That's really, really important to remember because that leads to hearing loss. Also, muscle weakness, irregular heart rhythms, and hyperglycemia as well.